Hello, my name is Christof Radler. I'm head of the pediatric orthopedic team in Speising Hospital in Vienna, and today I want to talk to you about standard AFO for clubfoot and atypical clubfoot, a unified approach. Now, the Ponseti method is still the gold standard for treatment of clubfoot. There is a big body of literature out there to prove this, and so up to date, this is what we need to do. Regarding bracing, the original paper by Ponseti and Smoley from 1963 showed that the splints were used for full time for a period of about 3 months and then at night for about 21.5 months. In this original paper, the recurrence rate was 56%, which is rather high. And recurrence was usually around the age of 2.5 years. Why? Because that's the time when the brace was stopped. So even back then, Ponseti realized that this bracing time is not enough, and he recommended to use the braces up to the age of 3 to 5 years to prevent recurrence. I think that's a very important message here. Additionally, he recommended to overcorrect the feet into 60-70 degrees of abduction. And if we look at the later literature, we see that those two details change the recurrence rate substantially. Now, why do we brace? The brace, the abduction brace, keeps the foot in maximum abduction. And the subtalar joint is at its maximum reposition. And that's what we need to do. We want to stretch the medial soft tissue. This tissue, we learned that it can be contracted and is part of the problem. And we prevent recurrence of equinus. Clubfoot treatment is not a sprint, it's a marathon, it's a journey. And ideally, it takes us from a foot, as you can see in the left picture, to a very nice and functional foot, as you can see on the right-hand side. And this is the same patient. And this is what's possible by following very strictly the Ponseti method and by applying a good brace and ensuring compliance with bracing and removing barriers to adherence. Now, as you can see, so if you would look at this from a timeline, these first 3 steps, the active treatment phase, is in fact quite short. Usually we do 4 to 6 weeks of casting, then tenotomy, and the last cast for 3 weeks. So that's a short time compared to these 4 years that follow that need bracing to prevent recurrence. So this is what we want to look at. Now, when do we start with the brace? And what's the prerequisite to start? So we start after removal of the last cast. In normal clubfoot, that means when the foot is fully corrected, subtalar abduction is possible, or abduction of the foot is possible to 60 to 70 degrees, and with a minimum dorsiflexion of 15 degrees. How do we get there? Well-molded casting and the last cast 60 to 70 degrees abduction, that's very important. And this is a detail which is sometimes not recognized so much. And the other thing is, of course, we do an Achilles tenotomy in cases if the dorsiflexion is below 15 to 20 degrees. Sometimes we see cases or feet where the dorsiflexion seems to be good. Then we always need to check the hind foot. Is there really good dorsiflexion? Is the calcaneus moving freely with the midfoot, with the forefoot? And in doubt, if you can do a lateral stress dorsiflexion view. And in some of those feet where the hind foot is not flexing freely, and you feel you have some of the motion from the midfoot, you might see a picture like that on the right side. In those cases, I would still recommend to do a tenotomy despite clinical dorsiflexion, because you need this dorsiflexion from the hind foot and not from the midfoot. So the tenotomy is a percutaneous Achilles tenotomy. So it's not an Achilles lengthening. It's of course not an open Achilles lengthening, and it's also not a mini open lengthening. So by following the technique and being careful. This is a surgery that can be done safely as a percutaneous procedure. And you can see the before and after. You usually gain around 15 to 17 degrees of dorsiflexion. We also showed this in a paper many years ago. So what about atypical clubfoot? Also, of course, we start after removal of the last cast, but now the situation is a little bit different. We start with the bracing when the foot is sufficiently corrected. So what does this mean? We want to have a subtalar abduction of at least 30 to 40 degrees and a minimum dorsiflexion of at least 5, better 10 degrees of dorsiflexion after tenotomy. And this can be a tough thing to get. Let's look at the atypical clubfoot a little bit closer, because it's something which is challenging and needs special attention. Atypical clubfoot show a severe cavus and equinus and a severe contracture of all the calf muscles. There is often a crease in the distal area of the plantar arch and a deep crease above the heel. The heel is in a severe and rigid equinus and in a very rigid varus. And this is also the problem during casting. That's one of the main problems during casting. In the course of treatment, sometimes the metatarsals plantar flex even more, especially the metatarsal 1, and we get a short big toe. There is a very nice paper on the treatment of the complex clubfoot by Ponseti and co-workers, and it's an absolute must to read through this and to get familiar with this kind of club feet, because I think every one of us has come across one of those. Atypical clubfoot might start out very, very unsuspicious, like the one on the left side. This is not a severe clubfoot. It's not turned in a lot. There's not a lot of adduction, but you also can see that there is quite some equinus, and there is like a cavus, which is more like a transverse crease instead of this cavo-adductus that we usually see in the newborn club feet. And those are feet that can turn right into the foot that you see on the right side. That's in fact the same foot. How can this happen? This can be the result of bad casting. And even if you're experienced, you might find a clubfoot that is more rigid than you were experienced. Sometimes it's also from really insufficient casting. So you can see casts like those might keep the baby from the cold, but is something that is really dangerous. They slip in those casts. When the babies slip out of the cast, they're still stuck within the cast. The heel is crashed against the back of the cast, and the forefoot gets swollen because of this. And what comes out of this is a very complex, iatrogenic complex clubfoot. So a well-molded cast is the prerequisite to prevent atypical clubfoot. They are very difficult to turn around. So sometimes you might get a clubfoot that comes to you like this, or you might have created it yourself and then you want to turn it around. And this can be a challenge because the feet are really very tender. The babies cry if you touch it. The skin is like a little bit like in a reflex sympathetic dystrophy case, bluish and sometimes even a little bit purple. The first toe is very short, so this takes a lot of detailed casting and a lot of experience to turn around. Now, what are the treatment modifications that have been described by Dr. Ponseti? We need to abduct very carefully and slowly. So one of the problems is that in those feet, the calcaneus is extremely stiff and is extremely in equinus and doesn't want to move with the abduction that we do in the forefoot midfoot area. And this is what might result. If you still keep abducting, you might see this midfoot break like you see it on the X-ray. So this is really a rocker bottom in the other plane. Yeah? You can see here there's a disengagement in the Lisfrau and Chopard joint, and you get this very complex distorted feet. So what we need to do in those cases is to cast very gently, grasp the foot by the ankle and dorsiflex the foot with both thumbs and very gently. You need to be careful not to create a nutcracker effect. We don't want to smash the talus. That's very important. So whenever you do this dorsiflexion, it's a dorsiflexion in the midfoot and not in the hindfoot. Now, with good casting, with a tenotomy, you might be able to turn this around very nicely, and then we start with the bracing with a different situation, not with 60-70 degrees, but with 30 to 40 degrees, and make sure you get at least this 5 degrees of dorsiflexion. So afterwards, otherwise it will be very difficult with bracing. There are different braces, and we need to decide first which AFO shoe to use, which sandal to use. Of course, there is the standard sandals, but there are also advanced options like the plantar flexion stop. The plantar flexion stop is a support for complex clubfoot. It counters the plantar flexion that we usually see in complex clubfoot. Still, you need to be very careful that the heel is down well, because only if the heel is down well in the shoe and you can see it well in the holes in the shoe, you get the benefit and you get the correction you need. There is a toe stilt sandal which aims to stretch the muscles and ligaments, and also it should improve the balance when standing with the bar. So this of course can only be effective if both sandals are toe stilt sandals. You get this resulting 7 to 10 degrees of dorsiflexion, and of course it only makes sense when the babies start to stand. You can start to use it when they start to stand in the grip, and you can also start to use it and do some standing outside of the regular bracing protocol to stretch the Achilles tendon and to stretch the calf muscles. There is a combination of the two. It's the plantar flexion stop toe stilt sandal. This is a very nice combination, but you need to be sure with those two things. So one thing, that the heel is down well, because this means you need to have more than 10 degrees of dorsiflexion, because otherwise the heel doesn't come down. And the other thing is, you need to be sure that when the child stands, not the knees are hyperextended in recovadum, but that the dorsiflexion stress really gets to the ankle joint. Now, if we look at the bracing and how we need to set the brace for a good start, we can look at the 4S. There is setting, socks, size, and straps. So setting is very important. We need to set the brace on the clubfoot side to 60 degrees of abduction. In atypical casts, we go to the abduction which you achieved in the last cast. It's usually around 30 to 40 degrees. That's where you want to go. The healthy foot goes to 30 to 40 degrees again. And then, of course, it's very important to set the size of the bar, the width of the bar. The connectors of the bar should be on shoulder width. As you can see in this picture, that's a good size. Socks are important. There are many different sock designs and socking options that are not possible. Of course, you can't use you can't use socks with big teddy bears, but also nice stitches are not so ideal, because those stitches get really pressed into the skin, and the socks need to be a tight fit. So it's very important that we don't have any folds in the socks that can make pressure sores on the skin if left on for a long time. There are special socks available. There are double layer socks available, which are very useful. And so make sure that you get the right socks. Too big socks are usually a problem. Big folds, or also very thin socks, or also socks that are very, very fluffy. Might look nice, but again, sometimes difficult to brace. As I mentioned before, the size of the bar is very important. A too big or too wide bar can be quite difficult for the child, Additionally, you get less dorsiflexion stress, so that's another thing, and you have more stress on the knee joints, especially when the baby sleeps on the side, which is something we usually see. Now, whenever you see the child, and of course, especially in the beginning, check the brace size. So you always need to adjust it. Usually parents tend to make it a little bit too wide, or they tend to want to change it because they think the child grows. Of course the child grows, but usually they don't grow so quickly, especially not in shoulder width. So check it yourself, make sure that this is a good size, because that makes the baby or the child more comfortable. Sometimes, especially if you have a very, very small child, you really need to get a very small bar, or you need to have someone who is a little bit of a handy worker, handyman. So sometimes you need to cut the bar if you don't get the right size. Make sure that it's not too big, especially also in the beginning. So the straps must be tight. So we need to make the middle strap very tight, and again, this is also something that reflects on the size, because if the brace is very big, sometimes there is no hole left to make the brace tight enough. Sometimes if you look at this shoe looks terribly big, so you would say, no, definitely that's not possible. In older children, it sometimes works. So you can see the heel is in a good position, it's tight, so yeah, not a big problem. But especially if you start out with bracing up to the age of 1.5, a too big brace usually is the source of trouble. The straps should also be in a good condition. Some parents might want to take used shoes, which can be fine. But sometimes when the straps are very stretched out, it's difficult to get a good position and to get the heel down nice. Like in this example, sometimes the next hole is too tight, this is too stretched out, so be careful for that, check it regularly. So when we start out with the brace, it's very important to teach the parents exactly how to use it. So you want to put the foot in a mild dorsiflexion, press down the heel and really slide it back into the heel box. You can wriggle a little bit the shoe that you really see that the sock is nicely visible in the heel holes. We want to fix the middle strap first. Why? Because it's by far the most important. And it needs to be very tight. In unilateral clubfoot, it's usually easier to do the clubfoot first. As I said before, prevent falls of the sock. And of course, the parents need to check regularly for slipping of the heel. The heel must not come up. The heel should be visible well in the heel holes. So this is a short video that really shows how we start out using this. We grab the feet, a little bit of dorsiflexion, put it in. Sometimes when the cast comes off after 3 weeks, the skin is a little bit tender. The babies sometimes don't like this first fitting of the brace, but still bracing must be started immediately. Don't wait for 3 days, 4 days, 5 days. You will lose correction. So you need to start bracing immediately. When you first fit the brace, you need to tell the parents, don't count the holes, don't mark the holes, because the new brace will stretch, and very quickly, after a couple of hours, you need to put it like 1 hole more tight. And this is something that we usually see. Most problems come from this middle strap not being tight enough. Very little problems comes from this strap being too tight. So that's what we usually see. Demonstrate it to the family and ideally have it shown back to you. So what about bracing the atypical clubfoot? Again, the same thing, and especially in the atypical clubfoot, it's a little bit more challenging, because now you need to be very careful that the heel is down well. Why is it more difficult? Because they have less dorsiflexion, so there's more risk that the heel comes up when they kick and struggle a little bit. Also, you need to be very careful if the skin is already sensitive. So you need to make sure that the skin is fine. Parents need to check the skin, and parents need to know that they can come to you anytime, that they can contact you anytime if there is a problem. If the brace works for 6 weeks in the atypical clubfoot, usually it works. Usually it's a win. Sometimes not. Sometimes you might encounter blisters and bruises. There can be different reasons. Definitely a reason is if the foot was not corrected well. Definitely a reason can be is if the middle strap is too loose, because sometimes then they kick, they move, and with kicking and moving, they get these blisters also in the heel. Also sometimes it can be too tight with some sweating, so the parents shouldn't cream too much, that there is not a skin maceration from a too wettish skin. What about blisters and bruises on the heel? Again, this is definitely a thing from not too tight, because they kick, they move the leg, and then they really move at the back of the heel, and they get these blisters. The blisters turn into small ulcerations that can turn into big ulcerations if you're not careful. So what's the solution? Again, you need to identify it early. If the parents tell you the heel is very red, you need to act immediately. They need to make the middle strap more tight. There is some bandages, special wound dressings that you can use, but this is something you need to address early. Once there is a full-blown ulceration, then you need to recast it, because you can't leave it just free. So in those cases, it makes sense to put on a cast for maybe 2 weeks, do a good molding at the heel, a molding above the heel, so that there is no pressure on the heel, but above the heel. And usually after these 2 weeks in the cast, the heel looks fine again. But of course, only if the cast was well molded. If they slip in the cast, you might be back to the old problem, or you might have even increased the problem. Luckily, those problems are very rare. This is a problem that we see more frequent, which is not a problem. Sometimes the feet look a little bit funny because all the fat moves away from the brace. So where the brace is tight, there is no fat, and all the fat moves above and below this area. So sometimes you see this little small balloon in the front of the foot, which is not like a swelling from edema. It is just the fat that moved away from the tight middle strap. And also sometimes you see this fat bulk above at the end of the shoe, at the upper rim of the shoe, which is again from the same reason and is absolutely no problem. And these are problems that just go away, or these are signs of bracing that just go away when you reduce the time in the brace. In fact, it's something to show you that there is a very good brace compliance and time in the brace. So what do we have to do to ensure a successful bracing? You need to use this time that you spend with the parents when you do casting, and you need to tell them that the brace is important. You need to tell them about the importance of the brace, about the rate of recurrence without the brace, and you need to take away their fears. They might fear that the child cannot kick so much, that they might have a slower development of the motor ability. You need to tell them that this is not the case, and that they can be assured that the child will develop normally. They should make the daily pauses from bracing at the same time. It's important to get a regular routine. When the brace is off, the parents can stimulate the foot. They can stimulate the side of the foot so that the baby extends the toes. That's a very nice thing to do, and that's also important for muscle balance and for later development of eversion. Allow for tummy time, and a very big thing is, of course, to get connected with other moms or dads in the same situation, with other caregivers in the same situation. So a support group is a very good thing. You want parents to talk to each other. it's an important thing. They sometimes have solutions and tips for problems that you might not even be aware of. So what should we not do? We need to tell the parents that they should never remove the brace when the child is crying. Of course, they need to check for blisters and for bruises, but they should put it back on. Especially in the older child, there's a very dangerous connection of putting the brace away when the child is crying, because children are very, very intelligent, and they learn this very quickly, that when they cry long enough, the brace is removed. And once they go down this road, it's very difficult to turn it around. So never remove the brace, not for tummy aches, not for normal mild fever, not for teething, not for sleepovers, and not if granny is around. Or so the more regular, the more routine this is, the easier it is for the child, and the easier it is to go all this way to the age of 4 to 5. As I said again, failures do happen. Mostly it's shoes put on not correctly, not enough correction, wrong size of the sandal, and not enough prep talk. So that's very important. So we need to do this. We need to ensure that the family has all the information they need to succeed with bracing. Especially in the first year of life, families are very motivated to do this. They want this to succeed. They want their child's foot to turn out as best as possible. And especially in the first year, if there's a problem, many times we have to reflect and see if there's something that we can do to make it better. And of course, we need to check them regularly. So latest after 2 weeks, you should check that it works well with the braces when you first give them out. And if you have very demanding families, they will contact you, or they contact you already very frequently, then of course 6 weeks are enough, because they will come if there's a problem. It's the ones that might not come that you really need to follow closely. What else can we do to make it better? Have a good orthopedic technician in your clinic, someone who knows what you're doing, knows what's important, that can maybe answer some simple, more technical questions for the parents, someone who is your ally. Be available, or have someone available if there's a problem. So I always tell my parents, if for some reason you can't use the brace for 1 or 2 nights, you need to contact us. That's important. You don't want to lose correction and then find out you have to start over again. And of course, written information is very helpful, and we need to explain things we know parents are a little bit anxious about, like overcorrection. So now my child is very flat-footed. Should I stop the brace? Or the child walks with the feet pointing outwards. Is this something where we need to stop the brace? No, this is a normal part of the journey, because, as I said before, this is a long engagement. And at some points, some things are normal and others are not. What do we look for? Like at every visit, we ask how many hours is the brace used? So are there any problems with sleeping? Are there problems with the skin? Problems with the brace? So ideally, you want to see mom putting on the brace. This also gives you a little bit of an idea if it works well, if there are any things you can observe, if there are any things that can be improved maybe. And also you can check the brace a little bit for wear and tear related to the duration used. If this is a brace that has been in use for 6 months, it should look the way. Nevertheless, don't blame parents. The most important thing is we're doing this for the children. So it doesn't make sense to blame the parents. You're not using the brace right, because this might just build a new barrier for adherence. So again, the parents are your allies. You need to talk to them and find out what you can do to improve it. So as you've seen before, this longest time is year, I would say 2 to 4. This is usually where it can get a little bit difficult. And That's where you really need to have perseverance, and you need it in year 2, in year 3, and in year 4. Many times, especially around the age 2, 3, when there's sometimes a phase where it gets a little bit more so difficult with the brace and sleeping, there starts to be some arguing. But we have to tell the parents there is no plan B. We are aware that bracing is a major challenge. We hear the parents. We know it's difficult. We don't suggest it's not difficult, but we need to talk to them. And if you don't like talking, you need to find someone who does. Maybe a nurse, a physical therapist, but parents need to be guided, and you need to walk this way with them. Another very important thing, there is no unilateral brace, especially not for the first 3 to 4 years. This is not a plan B, and this is something the parents need to be aware of. There is no plan B, so we need to go through all these steps to make sure that we have success and that we arrive in the end at a well-corrected, functional foot that we can achieve thanks to the Ponseti method and careful bracing, using the right technique, the right settings, and the right brace. Thank you very much.